Good evening, everyone. I welcome you all for today's IMA subcommittee webinar. So before beginning the webinar or before the speaker talks, I just want to begin the session with IMA prayer. So may everybody be happy, may everybody be healthy, may everybody be free from pain, may everybody be free from sorrow, may we be the healing cure beyond every greed and live. Okay. So today's topic is clinical depression, a case-based discussion. So me being a gynecologist, I encounter many patients. Nowadays, we encounter many patients after treatment of IVF or with a bad obstetric history saying that ನಾನು ಡಿಪ್ರೆಷನ್ ಅಲ್ಲಿ ಇದ್ದೀನಿ ಮೇಡಮ್ ಅಥವಾ ನನಗೆ ಲೋನ್ಲಿ ಫೀಲ್ ಆಗ್ತಾ ಇದೆ ಲೈಕ್ ದೀಸ್ ಟೈಪ್ ಆಫ್ ಪೇಷಂಟ್ಸ್ ವೇರ್ ನಾಟ್ ಬಿಫೋರ್ ವಿ ಅಂದ್ರೆ ನೀವು ಮೊದಲು ಅಷ್ಟು ಇರ್ಲಿಲ್ಲ ಸರ್ ಬಟ್ ನವಡೇಸ್ ದ ಟ್ರೆಂಡ್ ಇಸ್ ಇನ್ಕ್ರೀಸಿಂಗ್ and patient herself is coming to us saying that I am in depression or I am feeling loneliness or I am being carried away, see whatever it is. So as the IVF, like I am speaking about my field, as the infertility rate is increasing, the depression rate is also increasing, I think, sir. Concerned to my department. So many patients, I don't know about other pediatric and all, but obstetric, related to obstetric, they come with a bad obstetric history or they come with IVF treatment saying, ನನಗೆ ಹಿಂಗ್ ಆಗ್ತಾ ಇದೆ ಮೇಡಮ್ ಅಂದ್ರೆ ತಲೆ ಸರಿ ಇಲ್ಲ ಡಿಪ್ರೆಷನ್ ಅಲ್ಲಿ ಹೋಗ್ತಾ ಇದ್ದೀನಿ ದಟ್ ಐ ಆಮ್ ನಾಟ್ ಮೇಂಟೈನಿಂಗ್ ಬ್ಯಾಲೆನ್ಸಿಂಗ್ ಮೈ ಫ್ಯಾಮಿಲಿ ಲೈಫ್ ಅದು ಇದು ಅಂತ ಸೊ I hope that I'll get some good information from both of you today on this topic, sir. So now I request our chairperson, Dr. Lakul sir, to talk few words before we begin the session.
I am
Okay.
a case president.
Can you hear, madam?
Yes, sir.
Okay, can you hear me?
Yes, sir.
Okay. Good evening to all.
Good evening.
Good evening to all. So I really very happy to see you all because of this academic subcommittee doing a wonderful work, series of webinar. Today we have got a very important topic like clinical depression case-based presentation. For this, I welcome all the esteemed guests and our secretary Karunakaran and past chairman of this higher education past chairman and also past vice president of IMA KSB Harish Telantabettu, our academic subcommittee chairman Sanjana Tellur, and also esteemed guests of this evening, Dr. Samir Kumar Praraj, a good speaker, a native speaker from Manipal, and also the chairperson, Dr. Ajit V. Bide. Really, we are fortunate to have a good speaker along with our very good psychiatrist like Harish Telantabettu with us and all the esteemed members. I don't want to take much time. As we all know, depression is a mental disorder. Nowadays, we are having a lot of problems with mental disorders like elevation, also depression. 280 millions of people of all ages suffering. And after this COVID, as all of you know, the student community, because of the COVID, the increase in this depression state is very much. I don't want to highlight anything about the depression because we have got a very good renowned speaker and also the chairperson. With these few words, I hand over this to our chairman of subcommittee, Sanjana Tellur, madam. Thank you.
Thank you, sir. Thank you, sir. I'm thankful or will be thankful to Harisha sir for getting the speaker, Dr. Samir, and a chairperson, an eminent chairperson, Dr. Ajit Bide for this today's webinar. Now I request Harisha sir to give an introduction about our chairman.
Thank you, Chairman, Madam. May I request Dr. Karunakar sir to speak a few words as a secretary of the IMA KSB state branch?
Sir, not required. We are listening to. We are keen to listen to the speaker.
Fine.
Anyway, you invited me. I take this opportunity to speak a few words. As it's already been mentioned, we have a wonderful speaker to educate us on this important topic. obviously one question which comes to my mind at this point of time. Is this all people who remain silent are a potential depression candidates actually? Those who remain silent, lonely, solitude, is it all depression? It's just a pop-up question to our speaker before starting. I'm sure it's widely rampant across the doctors and the community. Issues may be anything ranging from the family, personal, or it may be professional things. There are plenty of things to listen. And we must appreciate the academic committee works in bringing out the best academic works from the best faculty through the IMA platform. And the committee is doing extraordinarily well. As a IMA KSB, we are very happy with the work done by. Thank you so much. It's over to you, sir.
Thank you, sir. Thank you for that short comments. Now, may I request Mr. John to share the slide, the introduction slide. It is my privilege to introduce our senior psychiatrist, very dignified and a scholar, Dr. Ajit V. Bide, sir. He is alumnus of St. John's Medical College and got his MD from NIMHANS, Bangalore. He is emeritus consultant in psychiatry at St. Martha's Hospital, Bangalore, where he has been working for the past 35 years. And he also introduced postgraduate program in family medicine. He is the past president of Indian Psychiatric Society. He was president in the year 2018-19, and he chaired many subcommittees and task forces. Naming few of them: chaired ethics committee, advocacy committee, boundary violation task force on LGBT, and also past literary editor of the IJP, Indian Journal of Psychiatry. He was the president of Indian Psychiatric Society South Zone as well as Karnataka State. He is a popular speaker at public and professional fora on various mental health issues. His areas of interest are personality disorders, anxiety disorders, youth mental health, psychotherapy, evolutionary psychology, preventive psychiatry, general hospital psychiatry, consultation and liaison psychiatry, rehabilitation, media and mental health, literature and mental health. Also actively interested in literature, performing arts, and Indian history and music, as well as physics. May I request Mr. John to share a video regarding his talent. He's a movie actor also.
लॉकडाउन अकेले बिताकर समझी कि अकेलेपन में कब से जी रही थी। एक तरफ लोग क्या कहेंगे का डर था, दूसरी तरफ फिर से जीने की उम्मीद। इसीलिए जब घर से निकलने की इजाजत मिली, मैंने खुद को अपने डर से निकलने की भी इजाजत दे दी।
एक नई आजादी का जश्न मनाओ, स्माइल करो और शुरू हो जाओ कोलगेट।
So one such episode. Now he has got many articles, the scientific articles in his name, and he has presented many presentation also. So here I present Dr. Ajit Bide sir. May I request him to introduce today's speaker, Dr. Samir sir. Thank you.
Thank you, Harisha. President Lakol and other functionaries of the IMA KSB, of which I am a member since 37 years. This is the third time I've been called to be part of the IMA academic programs. Thank you for having me over. It gives me great pleasure to be here to chair a very articulate, actual researcher fellow of ours. Let me introduce our speaker today. Dr. Samir Kumar Praharaj did his undergraduate studies at Guwahati from the Guwahati Medical College, and subsequently did his postgraduate qualification from the very well-known Central Institute of Psychiatry at Ranchi. He did both his DPM and his MD there. Currently, he heads the prestigious Department of Psychiatry, and also is a coordinator of the Clinical Research Center for Neuromodulation in Psychiatry at the Kasturba Medical College, Manipal. He has some prestigious fellowships, GSMC FAIMER Fellow 2017. Samir, you'll have to expand that for me some other time. And also the Department of Biotechnology India Alliance Fellowship in 2020. Samir's areas of interest are psychopharmacology, addiction medicine, non-invasive brain stimulation, on which I have heard him a couple of times, and medical education. He has publications in peer-reviewed journals and book chapters as well. He is the Chief Associate Editor of the Indian Journal of Psychological Medicine. May I request you to turn off, mute your mics, everybody please, except the speaker. He has received very many awards, prominent among them, the Best Resident Award at the CIP Ranchi in 2007, and I'll tell you that's a very keenly contested award. The Samuel Gershon Young Investigator Award, ISBD 2008, and he has also received travel awards and grants for early career psychiatrists, another prestigious achievement by him. Samir has also received very deservedly the Professor Raghuram Distinguished Young Teacher Award, which is given to teachers below the age of 45 by the Indian Psychiatric Society, Karnataka State Chapter. Samir, thank you for being here. And I'll just say a couple of words about depression. We've already heard from Dr. Sanjana, from other specialists also, about how pervasive depression seems to be, how often it is comorbid with several other physical conditions. My fear is not that we ignore depression, but that we reach out too easily to use only pharmacology for it. No doubt, when I was a young doctor, they used to laugh at psychiatry and say 4.5 diseases and 5.5 medicines. The whole scope has grown quite a lot. We have so many subdivisions of depression, which is likely to put off non-psychiatrists. It's very important for us to know that depression comes in various shapes, various sizes in terms of severity, and most importantly, it comes wearing masks. Depression is not easily revealed, as Secretary Karnakar and Harish alluded to earlier. So, to speak to us on clinical depression with a case-based approach, over to Samir.
Good evening, everyone. Thank you, Ajit Bidesar, for that introduction. I think you summarized the whole topic really well in few lines. And at the outset, I want to thank IMA KSP Specialist Dr. Harisa for inviting me here. It's always a pleasure to be part of IMA programs. So I'll just share my screen. I hope I am audible enough.
You're quite audible.
Yeah, thank you, sir. So, so today we'll be discussing clinical depression. I would always prefer to actually discuss this face-to-face, but then online it's little challenging that way to interact with people. But I would love if anyone stops me in between and ask any question. Maybe I'll also raise certain things if anyone wants to, let's say, interact. You can just unmute and you can answer those. So we'll start with one case first. So this Akash, 18-year-old male student, presents to emergency with a slashed wrist following breakup with girlfriend. Reported feeling sad, expressed that life is meaningless now. It is better to die. There's no prior history of any other psychiatric or medical illness. And after a week, he could get back to his usual routine of studies and started preparing for the competitive exams. So any thoughts about this? What could this be? Okay, I'll go to the next one. So we'll discuss a little bit about this again. The second case, see, Veena, a 30-year-old housewife, presents with 3 weeks of sadness of mood, loss of interest, decreased sleep and appetite following death of her husband. She reported feeling lonely, had occasional thoughts of death, and felt guilty that she couldn't do anything to save her husband. No past history of any psychiatric illness, no current medical illness. Now, what could this be? So we have two situations, two cases. So would anyone want to respond to this? So does any of this case have depression? You can write in chat also if you want.
Sir, case 1, acute stress reaction.
Right. Case 2.
Case 2, normal grief reaction.
Normal grief reaction. Okay. Yeah.
May-
We'll discuss about that. So the diagnosis of depression, what we consider clinical depression, is something slightly different from what usually people understand depression to be. So we discuss about normal sadness and in one extreme, and a clinical depression, which is a very clear-cut syndromal depression at the other side. And there are many states in between. So we all have periods in which we get disappointed because of certain things. So that itself doesn't amount to depression. So there can be a normal sadness of mood, which can last for minutes to hours, or maybe even few days. So if you see the first case, the one that we discussed, there was a event, and following which there was some sort of sadness. There was a reaction to that, and the person actually, let's say, started harming oneself. But then the symptoms lasted just for a week. So so to say clinical depression, so the symptoms should be there for certain period. So the cutoff that we say is around 2 weeks, and the person should be actually feeling depressed, which is a pathological sad mood, which basically should be present throughout the day, most of the time of the day, most of the days in these 2 weeks. So it is not just feeling sad for a short period of time, but it is the persistent and pervasive sadness, which is a hallmark of pathological depression. So in the first case, possibly the boy didn't have a clinical depression. It was a sort of depressive reaction which reduced, which let's say resolved without developing a syndromal depression. So like you can see in this the diagram below, so you can have disappointment, discouragement, sort of misery, and gradually as so if you have despair, sorrow, or anguish, which are more characteristic of possible clinical depression. So we need to distinguish between the normal sadness and what is a clinical depression. So that is one. Second thing said about the second case is said about grief reaction. I know some of the things could be a little simplistic for psychiatrists here, but then I thought I'll keep it simple so that people from other profession would benefit. So grief reaction is another normal reaction which we see following any kind of loss or other kind of injuries. So typically a grief reaction, again, there won't be a persistent and pervasive sadness of mood, but there will be waves of this sadness which will come and go, and in between those periods the person feels better. So whenever they think about the loss, any kind of loss, they would have waves of sadness. So and the other clinical features that I'll be telling next will not be there. So that would be a normal grief reaction. But yes, sometimes grief reactions can also be prolonged, or it can be pathological as well. Anything which is not a syndromal clinical depression, it would fall under, let's say, something what they call adjustment disorder. So any stress or any particular situation, any change that happens, and person is trying to adjust to that particular situation, they can have some features of depression, which may not be clinical depression, what we call subclinical forms of depression or depressive reaction. So these are not clinical depression. So then what is clinical depression? So our diagnosis mostly is based on certain criteria. We talk in terms of a pathological depressed mood, which is the core of depression. So in absence of a depressed mood, it is very difficult to diagnose depression. So here we are talking about that pathological persistent and pervasive sadness of mood lasting for around 2 weeks. Now, in the current diagnostic system, now we are moving from ICD-10 to ICD-11. Another symptom which was also a core symptom, but then that has been given little more prominence, that is called anhedonia, or loss of interest in anything that is pleasurable. So the person loses interest in whatever they were doing, day-to-day work, whatever they like. They find it too painful to enjoy those things, so they don't enjoy those things anymore. So that is called anhedonia. So to diagnose depression, you should have at least one feature of depressed mood or anhedonia from the affective cluster. That has to be there. Previously, it used to be only depressed mood. I mean, in absence of depressed mood, it is very difficult. It's not possible to diagnose depression, clinical depression. Now, some patients, it is seen that they may not actually report a lot of depressed mood. Although we need to understand that most of the diagnosis of clinical depression is not subjective, it is more objective, in the sense it's not always what patient reports to you. If we base our diagnosis of clinical depression based on patient's subjective reporting, we may overdiagnose depression. And that is what happens when we are using any self-rated checklist or any, let's say, self-rated self-reported symptoms. So we should be using more objective measure, and the best measure is basically to do a clinical interview, and we should objectively feel that the other person is depressed. So that gives more, let's say, the diagnosis becomes more reliable in that sense. So most of the trained psychiatrists would be actually able to identify that. But yes, I mean, at least if someone is suspecting depression, it's better to send to a qualified person so that we can evaluate and then think about the treatment. So the core symptom basically should be either depressed mood or anhedonia. Patients with depression have other symptoms as well. So again, these are not all symptoms need not be present, but then there are cognitive symptoms like decrease in concentration. The person has less of self-worth. They think that they are worthless. They have a lot of inappropriate guilt. If you see that case 2, the wife was actually feeling guilty that they couldn't do anything for the husband. Hopelessness. They think negatively about the future. The thoughts of death. There could be actual suicidal attempts. There are other neurovegetative symptoms like disturbed sleep. Most common is decreased sleep, but then sometimes it can be increased sleep as well. Loss of appetite leading to weight loss, significant weight loss. Sometimes there can be the opposite thing as well. There can be increase in appetite as well. So I'll tell a little bit more about that later. Psychomotor retardation or agitation. So if the person is gloomy, not interacting, so the motor activity has come down. That is one of the most common presentation. Sometimes they can be agitated as well. They'll be pacing around. So that presentation can also be there. Like Vidya sir said, depression is not just one presentation. There are so many forms. So, but yes, the most common form actually most of the people will be able to identify. But then there are many atypical forms which possibly require a little bit more skill to identify. Reduced energy or tiredness is another symptom, which is another important symptom. It used to be a core symptom in ICD-10, but then it has been downgraded now in ICD-11. So out of these symptoms, you need to have one symptom at least from the affective cluster, that is depressed mood or anhedonia, And from the rest of the symptoms, you should have at least 4 more symptoms to make a diagnosis of clinical depression. Although just counting the symptom is not something which is very important, but then in depression, it still holds true. I mean, if you're able to elicit all the symptoms and to have a symptom count more than 5, that will be likely clinical depression. So this slide basically tells you about the different ways in which it can present from, let's say, normal sadness. Like I said, people who have normal sadness, usually they're able to get out of this sadness after some time. They still have some hope. They're not hopeless. They think about the future. There is not much impairment in any of the day-to-day functioning or any other activities. Whereas adjustment disorder, like I said, which is a very milder condition in which it's a subsyndromal kind of depressive reaction, which can sometimes happen when someone is facing certain situations. Little more than that would be something what we call, so like I said, less symptoms, but still it is a syndromal depression. Whereas those who have more number of symptoms likely to have a major depression, which definitely requires some sort of treatment, including even medications. Therapy. The patients who have, let's say, adjustment is without medications, also possibly some form of psychotherapy or counseling. We also need to be aware about another form of depression, which is a very severe form of depression, what we call melancholia. So it is, so if we distinguish melancholic depression from all other varieties of non-melancholic depression by presence of certain features, which is essentially there can be a very severe psychomotor retardation, and the kind of mood change that you see in melancholia is qualitatively very different than any kind of sadness. And possibly say I've never felt something like this in my life before. So it is very painful. The person who is going through melancholia, the mood state itself is so painful that many would actually think of death or maybe suicide. So it's extremely painful condition. And usually it's not reactive. The mood is not very reactive to situations. So whatever you do, it's very difficult to cheer them up. So that would be a very severe form of depression. And of course, I mean, this kind of depression will always require medications and sometimes even other form of treatment like ECT. And they do respond to medications and ECT very well. So identification and referrals would be actually very helpful if someone has melancholia, because the risk of suicide will be very high. And of course, there is another subtype of depression, which is again a very severe subtype, where psychotic symptoms are also there along with the depressive symptoms. Psychotic symptoms like the person has delusions and hallucinations. Most of these patients would report that so they have done something really wrong. There will be a lot of guilt, ideas of sin up to delusional level. They'll be hearing some voices sometimes which will be derogatory. They'll be basically abusing the patients. So again, very high risk for suicide. So if you have patients who have melancholic depression or psychotic depression, so that is when then this should be actually referred to mental health professional. There can be many different developmental presentations as well. Like in what we're discussing, the symptoms are in adults. So in children, the presentations can be very different. Many times, very young children may not actually report of depressed mood. They may not be able to verbalize that well. What they would present is with very vague somatic complaints, like let's say children reporting of abdominal pain, headache. Sometimes when they're separated from their parents, they will become very anxious. They may have irritability rather than depressed mood. So these could be slightly different kind of presentations in children. And also children present more with decline in academic performance, and then we need to suspect that possibly they could be having a mood disorder. They may not, because they're not working. So in other areas of functioning, it may not get reflected. And sometimes even just small things like they're not able to complete day-to-day school assignments. So missing those possibly could be indicative of something going wrong. And we know, I mean, these days there are other reasons which could also mediate. I mean, let's say children using, having a lot of screen time, possibly they could be actually having let's say underlying depression, which is not diagnosed, and so we need to be a little careful about that. Symptoms like hypersomnia and hyperphagia, that is increased appetite and increased sleep, which is just the opposite what you see mostly in adults, are atypical features, and they are much more common in children. So that is another presentation you may see in children. Similarly, in elderly also, the symptoms can be very different. Instead of usual mood symptoms, the ones that we discussed, they can complain of memory complaints, and then we'll be thinking about dementia. And many a times they're misdiagnosed as dementia, and they could be having depression. The distinction is very important, because if the diagnosis is Alzheimer's, I mean, we can hardly do anything to correct it. So at least pharmacologically, we cannot do much. But if it is depression, it is treatable. So more the reason why we should be actually diagnosing pseudodementia or depression in elderly. There can be other presentations as well. There can be psychomotor agitation. Many of the hypochondriacal or somatic presentations also are quite common in elderly. So these could be different presentations in different age ranges. The etiology of clinical depression, I'll not discuss a lot of theory, but just to summarize, so there has to be a genetic vulnerability for any psychiatric disorders, including depression. So not everyone will develop depression, but then someone who has vulnerability genes, so they're much more likely to develop depression, specifically when they are encountering some sort of stressful situations. Of course, there are certain factors which are risk factors, and there are certain protective factors. Like, for example, the person who is having good coping strategies may face adversity, but then can still able to cope and doesn't develop clinical depression. Doing physical exercise regularly, having a good sleep schedule. So they are all protective factors. Whereas other factors such as any childhood trauma, concurrent medical conditions, we'll discuss a little bit more about those, can actually precipitate depression in those who are vulnerable. And of course, I mean, there can be explanations at various level, at behavioral level that we already discussed, affective symptoms, cognitive symptoms. There are correlates at the brain level in which the specific functioning of specific brain areas are affected. So I'll not get into details, but there are specific neural circuits which are affected, and that could be actually target of treatment as well. Of course, we have some understanding about the molecular mechanism, the mechanisms in the sense of the neurochemical mechanisms like serotonin, dopamine abnormalities, and we have gone much beyond those basic monoamine hypothesis, and our understanding about depression is little better in the sense there are a lot of downstream effects like, let's say, BDNF and other neuropeptides which are affected. It's again another kind of illness, systemic illness, like, let's say, diabetes or hypertension, where when inflammation and neuroimmune pathways, these are also implicated in pathophysiology of clinical depression. So if you see the pathophysiology, it's actually quite complex. So the person who is having persistent depression, clinical depression, that will be a persistent activation of the HP axis, which can ultimately interact with the neuroimmune pathway. And that can explain some of the features of clinical depression. Again, I will not discuss much about this, but then the one thing that I want to just make it clear, like many people just think that, okay, someone is depressed and you just try hard, you'll be able to come out of this. So it doesn't happen that way. So patients would require specific treatment, like they require. It's almost like saying, okay, you have diabetes, you try hard, you'll get out of diabetes. It doesn't happen. You'll have to use medications or other form of treatment. Same way for depression. So once we diagnose, we'll have to treat in certain ways, be it medications or other forms of treatment. Otherwise, it doesn't get well on its own. Okay, I'll go to the third case now. So this is Mahesh, 21-year-old male, presented with depressed mood, loss of interest, disturbed sleep, loss of appetite, hopelessness, suicidal ideas for 3 weeks following a breakup. He had an episode of psychotic depression 2 years back, which required hospitalization and treatment. The mother had depressive illness, so all the investigations are normal. So again, if you see here, the symptoms, the core symptoms are there. So it has symptoms suggestive of depression. Duration criteria also will fulfill, more than 2 weeks. And they started along following a breakup, but then the stress actually doesn't tell you whether it is a depression or not. It's the symptoms, the severity of the presentation, which tells you whether it is a clinical depression. So anytime it follows a loss, it may not be a normal reaction. It can go to a clinical depression. So there's a past history of depression as well, and which was a quite severe episode. As you can see, it's a psychotic depression. Like I said, melancholic and psychotic depression are quite severe episodes. So here, and there's a family history as well. Mother had depressive illness. So depression runs in families. So as you can see here, this patient could be possibly having a recurrent form of depression, what we call the recurrent depressive disorder, and this could be the second episode, isn't it? So that is very apparent. So are there any other differential diagnosis in this case? So would you think about any other differential diagnosis besides clinical depression? Anyone? Is there any other possibility? Okay, so I'll give one more little information, more information. So in this, I just changed the previous case only. I changed two things. Instead of let's say decreased sleep and decreased appetite, if the patient presents with increased sleep and increased appetite, and if you see, mother had not depressive illness but bipolar illness. So what is the current diagnosis now for this patient? Will it be different? So the previous one and this one. So does it still remain a depressive illness, or is it something different? Do you have any differential diagnosis in mind? Yeah. So right. Okay. I'll answer that. So here, if you see the symptoms, like I said, the increased sleep, increased appetite, these are pointers towards a possible atypical form of depression, not the usual typical depression. Typical depression, you have decreased sleep, decreased appetite. So atypical depression is little more common in bipolar disorder. Now, in this patient, there is no history suggestive of prior manic episode. So I had one depressive episode before, and this is another depressive episode. But this depressive episode is slightly different in the sense it has atypical presentation. So that's the only difference. So diagnosis is still recurrent depressive disorder. If there was a past history of mania, then possible diagnosis would be bipolar disorder, right? Bipolar depression. Now, in this case, there is something else also which is important. Mother had bipolar illness. So that makes it little more likely that this patient could be having a hidden bipolar disorder. So essentially, a diagnosis of depression is not very straightforward. So you have to exclude certain conditions. So it's primarily a diagnosis of exclusion. So if you want to diagnose unipolar depression, you'll have to exclude bipolar disorder. So in this case, there is a possibility that this patient could be having a soft bipolarity. So a very established bipolar disorder, what we call bipolar 1 disorder, where there are clear episodes of mania or hypomania. In this case, that thing is not there. So it is a very milder form of bipolar disorder, but nevertheless, the presentation could be a bipolar disorder. And the treatment could actually be very different. So the first question is it unipolar depression? So not all depression are unipolar depression. Initially, depression is considered unipolar, but then those who are diagnosed with unipolar depression, subsequently around 40% of them, they are later diagnosed as bipolar disorder. So how do you identify who could be having a hidden bipolar disorder? So what are the signs of possible bipolarity? So there are actually many red flags. So you need to keep in mind all these things which could be possible signs of bipolarity. So any family history of mania, bipolar disorder, or psychosis, or past history of psychiatric hospitalization. If you see the first case example that I said, the first episode was depression, which happened at very young age. So we know clinical depression is not very common in adolescents or young age. It is much more common in middle age. So if a patient presents with first episode of psychotic depression, it's highly likely that they could develop bipolar disorder later. Very early onset illness, like I said, commonly with psychotic depression, retardation. So psychomotor retardation, which could be harbinger of, let's say, bipolarity. Cyclothymia is something like the fluctuations in mood which occur in both sides towards depression, towards hypomania, but which is not good enough to, let's say, make a diagnosis of bipolar disorder. It's a milder form, basically. Several episodes, 4-5 episodes within a very short period, few years. So that is again possible indicator of bipolarity. So certain features in depression, let's say what we call mixed features, so prominent agitation, anger, irritability, talkativeness, other features which can, or atypical depression. These could be features of bipolarity. Like that, when someone is treated with antidepressant, if there is sudden improvement and then appearance of hypomanic features, that can also suggest bipolarity. Suicidality is much more common in bipolar disorder. Substance use is more common in bipolar disorder. Seasonal pattern and specifically postpartum onset of depression. Again, high likelihood that they are going to develop bipolar disorder later. So we'll have to keep these things in mind. Okay, so another case. So this is elderly person, Basavaraj, presents with sadness, decreased interest, disturbed sleep for 2 weeks duration. Diagnosed with diabetes, hypertension for several years on irregular treatment, so poorly controlled diabetes and hypertension. And there was an episode of mitral infarction 10 years back. They had undergone stenting, had stroke 2 weeks back, which involved left frontal area. So which was picked up in CT scan. So what would be the likely diagnosis here? So again, if you see, the symptoms are, the presenting symptoms are of depression, and the duration is around 2 weeks. So that will fulfill the criteria, let's say. Now, is this, what kind of depression is this? So is this a primary depression? So we use the term primary depression for those where depression doesn't have any other etiology, any other known etiology. So there can be secondary depression, like how you have, let's say, essential hypertension and secondary hypertension. So essential hypertension is the primary hypertension. So similarly, you can have a primary depression. So, but you can also have secondary depression, secondary to many things, secondary to medications. So many of the anti-hypertensive drugs many other drugs like, let's say, steroids, which can actually precipitate cause depression. There are many medical conditions, specifically thyroid disorders, many other neurological disorders which can cause depression. So in this case, it could be possibly post-stroke depression, so related to stroke. And we know actually if you see the localization, it is a left frontal region. So we know actually strokes presenting with involving the anterior areas, left anterior areas of brain, are likely to cause depression. So we need to also identify, we need to rule out all these medical causes of depression before we say that it's a primary depression. So like I said, depression, it's a diagnosis of exclusion. Primary depression is a diagnosis of exclusion. You need to think about this specifically when the age of onset is little atypical. In this case, this symptom started at 68 years of age, which is little late. So all late onset cases, you'll have to think about medical conditions, go through what are different medical conditions which can contribute to the cardiac illnesses, diabetes, the medications for treatment of diabetes and hypertension. They're all likely to cause depression or worsen depression. Okay, we'll look at this case.
Sir, is there something called organic depression?
Yeah, so previously we used to call this secondary depression as organic depression. So we had a distinction of functional versus organic, but then we have given up that term organic depression. So essentially all depression are organic. I mean, when we say primary depression, they still have some biological basis. So it's an older term. So we just given up that term. We call them primary and secondary depression. So the older term was organic depression.
Thank you, sir.
Yeah. So case 5. So this is Ashok, a 45-year-old businessman, presents with 2 months of history of depression of moderate severity following loss in business. No past psychiatric history. Currently reports of death wishes, no active suicidal ideation, no medical comorbidity, good support system. So of course the diagnosis would be depression. So what is the treatment of choice? How do you treat this patient?
Sir, can we call it as adjustment disorder?
Yeah, I mean, if the symptoms are not fulfilling the criteria for, let's say, depression, it will be subsyndromal condition. So let's say if I say that this person has clinical depression, so presenting with features of clinical depression. So what would be the management strategy here? How would you treat this patient? So the treatment of choice. If the symptoms are less, it would be obviously adjustment disorder. But let's presume this patient has clinical depression. So so treatment of choice would be the first line drugs basically. So if you want to treat with medications, the first line drugs would be antidepressants, could be the SSRIs, which are the first line medications. So this is a meta-analysis which basically summarizes all first line antidepressants. If you see commonly used medications are SSRIs, escitalopram, and sertraline. These two are considered the most common medications nowadays, prescribed most commonly. There's a reason for it because the safety margin is good, and the drug interactions are also quite less for this. So if someone is having other medical morbidities, so it's easy to prescribe escitalopram, sertraline. But yes, other medications also can be used, mirtazapine, venlafaxine. But usually venlafaxine is a SNRI, which acts on dual receptors, not just serotonergic mechanism, but also as noradrenergic mechanism. So usually we will use SNRIs as second line, but then, yeah, I mean, some cases it will vary from case to case and also the presentations. So if there are more noradrenergic symptoms, possibly we can sometimes prefer venlafaxine as well. The doses we'll have to know what is the minimum effective dose, and that should be the target dose initially. Most of the antidepressant effect will start after 2-3 weeks. So it takes typically there is a delay in the effect. So many patients, when they're prescribed medication, they'll take medications for 1 week, then stop them. It doesn't help actually. So we'll not know whether medicine actually helped or not. So better to give a trial for at least 4 to 6 weeks in adequate dose. And the adequate dose for the medications have been defined. So if there is some response possible, we'll continue. Otherwise, we'll have to change medications. So tricyclics are not the first line medications nowadays because of the potential risk for toxicity in overdose. They could come as second line medications or third line sometimes. So typically in depression, if someone has depression, the acute treatment phase will be till the person achieves remission of symptoms, means there are no depressive symptoms anymore. And if someone achieves remission, possibly will continue the same dose of medications till person actually recovers. So that would be the continuation phase of the treatment. So usually will typically for unipolar depression will continue for around 9 months to 1 year. That's a period which a depression usually takes if it is untreated. So till that period will continue the same dose. And if it is just a first episode depression, possibly after 1 year, we'll try reducing and stopping it. And if it is a recurrent form of depression, possibly we'll have to continue even a maintenance. Sometimes we'll have to give prophylaxis. So there can be relapses if someone stops medications in between, or if someone has already recovered, that is has a sustained remission, there can be recurrences during the maintenance phase. These are the three treatment phases. So typically the treatment would last somewhere around 9 months to 1 year for one episode, first episode depression, if it is working. So we'll go to the next case. So what happens when someone doesn't respond that well? So this case, Hari, 35-year-old carpenter, symptoms of depression. Now symptoms are lasting for more than 6 months. He has already received trials of sertraline 50 milligram for 2 weeks with no improvement in symptoms. So initially he didn't tolerate sertraline. There are some nausea which improved with some symptomatic treatment. No medical comorbidity, good support system, no stressors. Now, is this a treatment-resistant condition? And what could be the treatment of choice in this case? So I said about the first line medications, if they don't work, so possibly you'll have to think about second line medication. They're not working, we'll have to think about treatment resistance at some point of time. And these are the cases which usually require referral to mental health professionals because they need more evaluation. But I will give some idea about what exactly we do. So is this treatment resistant depression? So that's the first question. So the consensus definition of treatment resistance basically is there are 2 trials of antidepressant medications from different classes. Means let's say 1 SSRI, 1 SNRI trials have been done with adequate dose. So adequate dose is defined and duration is usually 4 to 6 weeks, which is the adequate duration of trial. And of course, patients should be taking the medications because if adherence, if it is patient is not taking the medications, it doesn't help. So almost more than 80% adherence should be there. So then we say patient has not responded, possibly it could be a treatment-resistant depression. Now in this case, previous case, if you see the dose of sertraline was 50, that dose is adequate, but the duration is very less, 2 weeks. So basically this is not treatment-resistant depression. You should continue the same treatment for some more time. So around 1/3 of patients, they have treatment resistance. They may not respond to the first line and second line medications. Then possibly you'll have to think about the other strategies. So now another case, if you see again, patient with 42-year-old homemaker with depression on treatment, but so had good trial with fluoxetine 20 milligram, mirtazapine 30 milligram, both given for 6 weeks, good adherence. So means there is adequate trial of 2 medications of different classes. But depression is persisting now for more than 1 year. So like I said, most of the time depression resolves, but then sometimes it can be persistent depression as well. So currently patient reports of death wishes, but there are no active suicidal ideations. So the suicidality also actually determines what kind of treatment we will be offering. no medical comorbidity, good support system, no stressors. So I am basically ruling out other psychosocial factors which could contribute to depression, but then in this case, those are not present that way. What could be the treatment of choice? Okay, another case, if you see 56-year-old widow with depression, didn't respond to trial of escitalopram 20 milligram, some response to norepinephrine 50 milligram. The predominant symptoms include apathy, and investigations also show certain abnormalities. TSH is 8, so it's not a clinical hypothyroidism. So it would be more like a subclinical hypothyroidism, no other medical comorbidity. So what would you do? What would be the treatment of choice? So let's see some of the next slides. Possibly will come up with the. So if you have treatment resistant depression, the first thing is, of course, confirming the diagnosis. Sometimes there can be other diagnoses which we miss. So including personality disorder, bipolar disorder, like I said already, even patients with schizophrenia may not report certain symptoms. Look for other comorbid conditions. There could be other factors, substance use, personality disorder, which could be comorbid. That's why patient has not responded well. Medical conditions, like I said, thyroid disorder, anemia, vitamin deficiencies, these can be easily treated, and that can also take care of depression. So it can be secondary depression, it can be comorbid condition, so both ways. Some medications, like I said, which are very relevant. So steroids, antihypertensives, these can actually contribute to depression. So we need to review them. Ensure treatment adherence. The patient should be taking the medication. So you do a lot of education. Many patients will be apprehensive about taking medications, psychotropic medications. It can affect kidney, it can affect liver. So a lot of concerns usually patient report. We need to address them. We need to see whether social support is good. That can also be looked into. Other clinical factors, sometimes the medications and other treatment which are being used may not be evidence-based. So that is something, so that there are some medications which may not be given in good enough dose. So those could also be seen. So adequate dose, duration. So once you do this assessment, so what are the different strategies that you can do? So you can use any of the strategies. So optimize, dose, switch, sometimes augment, combine, or novel medications. The many other non-pharmacological strategies like ECT, TMS, I'll just tell a little bit in the end. So the other integrated therapies, food supplements, even other neurosurgical techniques. So I'll not be discussing much about those, but then I'll tell a little bit about the pharmacological strategies. So optimization is important. If there is a partial response, so if there is some response with medication, you've given good dose, but then some response is there. One thing that you can do is you can go up on the dose. You can use the maximal possible dose, and maybe sometimes duration also you can optimize. So that's the first strategy. So that's a Sertraline 50 milligrams. You can, some responses there, you can go up to 100, up to 200. So that is one strategy. If there is still inadequate response, possibly think about different sequence treatment options. What do we do next? So we have a major trial, STAR-D trial, sequence treatment alternative to relieve depression. So if you see, when person is not responding to one, you either switch to other medication or augment with other medications. The actual response rates are not very good. Even after switching or augmenting, the response rate increases marginally, specifically after level 3. The response rate actually comes down very less. So when do you switch? When do we augment? So if optimization fails, if there is no benefit at all, so the first drug that you had used, there is no change, no improvement at all, then you switch. There is no point continuing that medication which is not working. Or if there is some partial benefit, possibly augment. So there are some medications which I'll tell you, which we used to augment. Okay, switching strategies. If there is no response, like I said, so discontinue the ineffective antidepressant, start a new antidepressant. It makes more sense to switch to medication from a different class with different mechanism of action, but then even switching to the same class also has some efficacy because all SSRIs are not same. So there are differences between SSRIs as well. So clinically, you may actually see some response even if you're switching in the same class. So actually switching efficacy study wise, it's not something very great, but then yeah, it varies from study to study. So smaller studies will have more efficacy rates. So when to switch after first antidepressant trial? So not working, switch. Poorly tolerated, switch. No response, less than 25% improvement. Sometimes if it is less severe depression, patient is not suicidal, it's just mild depression. So you can maybe wait little longer, can give a longer trial. Some patients do respond if trial period is longer, up to even 8 weeks. Or sometimes patient wants actually, but it's not working, so change to something. So you can do that, but then yeah, after giving adequate trial. So which medications would switch? I said to different class. So that is one of the strategy that we do. Of course, there are specific guidelines which we need to follow, mostly related to the interactions, drug interactions, which we need to keep in mind. There's a role for older medications like tricyclics and even MAO inhibitor. So we have the MAO inhibitor now in India. So there are certain precautions. Again, they're all third line strategies. So if someone doesn't respond, we sometimes can use this. The combination strategy is basically when we combine two different antidepressants of two different classes. So that is another strategy which we can use. But then there are not too much of studies that way. But then one study, COMET study, actually says that it doesn't help much. So combining two antidepressants, it's not always very useful. There will be more side effects. It's not a good strategy actually. So augmentation is basically when you are not combining two antidepressants, but you are giving one antidepressant, there is some response. So use other medications which are not primarily antidepressants, but that can be used to augment. So the common augmentation strategies we use are lithium or sometimes even thyroid augmentation. Even if someone doesn't have hypothyroidism, we still augment with thyroid, but then it should be augmented with T3, which is best level of evidence. We don't use T3 that much. We'll use more of levothyroxine. Atypical antipsychotics have some evidence. Quetiapine, aripiprazole, the newer antipsychotics have effect for in unipolar depression. Many other medications which have been tried but are not helpful also we need to know, because they should not be used that way. There are some medications which lie in between, like dopamine agonists. Sometimes dopaminergic strategies can be helpful. We also need to remember that there is a very safe and effective treatment, which is ECT, which is actually underused. Many places, the patients actually could be a little apprehensive about ECT, but then you need to educate. If patient has severe depression, specifically patient has suicidality, psychomotor retardation. So these are the patients who were good candidates for ECT, and they respond very well. Melancholic depression, if the past response, the apprehensions about the cognitive side effects, the memory problems, it's not much actually. So the effects are very transient. Usually it's reversible. So maybe after let's say 1 month or 2 months, usually most of the memory problems actually disappear. So it's a very effective strategy, and specifically when you're using unilateral ECT, it's very safe, it's effective. So that is something that we should be discussing more. I mean, if patient has severe depression, should be referred to centers which have ECT facilities. There are other neuromodulation strategies which are coming up, specifically TMS. It's slightly different from ECT. In ECT, you use anesthesia and you are given electric current to produce seizures. TMS is basically a strategy which can be more like a day procedure, in the sense, I mean, ECT also can be a day procedure, but then this doesn't involve any anesthesia, but then the patient comes, gets a session, specifically with the newer strategy like theta burst stimulation. the facilities are there, it has actually reduced the treatment sessions to few minutes. So a patient comes, gets a TMS session, goes back. So they will require several sessions of TMS to see improvement. So whenever these facilities are available, they should be availed. Even the transcranial electrical stimulation is another strategy, which is again quite safe, although not very effective, like ECT and TMS. But these are other options which are available and can be used in patients. So another alternative for ECT, specifically for suicidal patients, is ketamine. This is a novel treatment, but then we have some evidence now. We do use this again. It can be done in outpatient basis also. So the typical strategy is using a subanesthetic dose, 0.5 milligram per kg, so over 40 minutes, slow intravenous infusion. But then there are other ways also of administering this. People have used it even the oral route also, but maybe the intravenous route is a little more effective. You may have to continue this ketamine infusions for, let's say, sometime few times per week. Let's say continue for 8-10 sessions possibly to see effect. Some patients have dramatic response even with first session or second session. So the new formulations which are also coming, so it's not available in India. So what we use is basically the intravenous formulation. And you don't need actually even anesthetist help, because you're giving a subanesthetic dose, so it doesn't cause any kind of problems that way. You can monitor easily, you can do it in OPD. So oral ketamine, like I said, can be used sometimes. Of course, do not forget about the integrated approach, means other methods also, like exercise, moderate exercise. This can be prescribed to all patients with depression. Although they find it difficult to initiate something, but then we can ask them to gradually get into this to 30 minutes thrice weekly for 9 weeks. This has good evidence for depression. Yoga, different forms again, and acupuncture, there are some evidence. Light therapy, specifically in people who have a certain form of seasonal affective disorder, these are also there. More used in West, not here much, but yeah, sleep deprivation also is therapeutic sometimes. You just don't let the patient of depression sleep. Next day, depression is gone. But then once he sleeps again, the depression comes back. So the effects are very short lasting, but then other strategies which can be tried in patients, many herbal supplements. Again, the efficacy plus minus, some have some efficacy. Psychotherapy, there are many different forms of psychotherapy. I will not discuss much, but then there is a specialized form of treatment. So better these are to be done by trained personnel. So patients could be referred to mental health professionals for this. Just before I stop, I'll just tell about, we have a neuromodulation lab in KMC Manipal. We do ECT, TMS, TES, the ones that I said. If there are patients who were not responding to persistent symptoms despite pharmacotherapy, they can be actually sent for treatment. And we are having a trial right now in which we can take patients, and all this treatment would be provided free of cost. So yeah, so I'll stop here. So this is basically volunteers needed for our trial. I'll stop here. If there are any questions, you can ask.
Sir, how to differentiate between depressive reaction and reactive depression? What's the difference, sir?
Yeah, so depressive reaction basically is a subsyndromal condition. So the patient doesn't have clinical depression. So that's a type of adjustment disorder. So what we say, so they will not fulfill the criteria for clinical depression. Reactive depression can be a clinical depression as well. I mean, like the one way to classify clinical depression is to say it's an endogenous depression or a reactive depression. So endogenous depression will have more biological basis, whereas reactive depression is have more psychosocial origin. The truth is actually there are no pure forms of let's say either endogenous or reactive depression. So all depression are endoreactive. So they'll have some component of endogenous part and reactive part as well. So yeah.
I
So
would
that
like to
is
say,
the difference.
I would like to say there is no such distinction.
Yes.
There is no depressive reaction
Yes.
or reactive depression. You might at best use a term like depressive reaction in the context of a stress the person has undergone, and his immediate reaction is colored by sadness. But I don't think there is any entity called depressive reaction in psychiatric nomenclature anymore. We have adjustment disorders with anxiety and depression, adjustment disorders mainly with anxiety, mainly with depression, and so forth. But I think everything is a reactive depression. And Samir, you're very right that this dichotomy of reactive and endogenous has disappeared. Also, I'm very glad you made the point that everything eventually has a biological root. Without the physics and chemistry of our nervous system, nothing can go wrong with the functioning of the mind. We have to accept that. So, incidentally, even psychotherapy has a biological basis.
Hello,
Sir,
Harishas.
Any question? Any more questions? Chairperson.
sir, anger
please go
turned
ahead.
inwards and depression. How to connect anger turned inwards and depression?
Yeah, that's one of the theory of let's say more like a psychodynamic understanding of depression, when the person is basically it's more like a understanding of depression in that sense, rather than expressing anger towards outside objects. It is basically acting on his own psyche, and so it's more like understanding. I mean, clinically, it's not something that you see.
Okay,
No, I beg to
sir.
differ. We do see it clinically, but you're right. It's a psychoanalytic concept advocated by many of Freud's earlier followers to understand suicide. So you turn your anger on yourself to the extent you're violent with yourself, and that violence manifests in suicidal ideation and suicidal acts. I'm also glad, Samir, you brought up the distinction between death wish and suicidal ideation. There is a transition from one to the other, but it's clearly distinct. Everybody who says, gosh, is not a candidate straight away to be called suicidal. We have to watch out that this person is more likely to be suicidal in the long run than people who don't have. The death wish progresses to suicidal ideation, and that was very well brought out in two of your cases.
So it is more that recurrent
sir,
form which is more important rather than just occasional some death wish, passive death wish. If it is more persistent, it is occupying more time, and the person is thinking about it again and again. They're the ones who are more likely to develop. So we'll have to be a little careful. So, thank you.
And sir, mood versus thought. Who is in the driver's seat? How to conceptualize negative automatic thoughts?
Sorry, I didn't
Whether he is,
follow the question. Yeah.
sir,
May I take that, Samir?
Yeah. Yes. Sir.
Because what you're calling thoughts are something which in our parlance nowadays, rightly or wrongly, we call cognitions. So these are thought processes that manifest with some belief which may be realistic or not too realistic. And Aaron Beck and his school of thought, for the cognitive therapists to start with, which slowly metamorphosed into cognitive behavior therapists, thought that faulty thought processes precede bad mood. The case is very, very apt, but it is a little overstated. So every depression is not based on faulty thinking processes, and one must not fall victim to believing that CBT can cure everything. When I was a freshly qualified psychiatrist, CBT was ruling the roost, and nobody talked about psychotherapy generally. They talked about CBT, CT initially, and then CBT. I think that case is a little overstated, though it's important. So when you have who's in the driver's seat if you ask a very graphic question like that. I think emotion is what we are really dealing with. Is that emotion founded in faulty cognitions? We must pay attention to that.
Sir, one question from my side. Like, does depression lead to any addiction, like shopping or drinking or whatever it is? Like,
Sameer's other stated area of interest is addiction. So I'd love to hear him on that.
So, yeah, I mean, of course, they are all linked in a sense. Addiction could be actually a symptom, a presentation of depression as well. So, so many patients who have addiction actually could have underlying depression. So there is a link that way. So when we assess addiction patients, so this is another thing that we need to keep in.
Okay, sir. Thank you, sir.
Sameer, one point that gets left out very often when people are dealing with depression is to explain to the patient every antidepressant we know of, with the exception of ketamine, has a latency of action. From the time you start the medicine to the time you will see a response is a minimum gap of 10 to 15 days. And everybody needs to be aware of that. I find too many people, including our fellow professionals, not explaining this adequately to patients. Very often patients think, you take a paracetamol, your fever comes down. You take an antihistaminic, your cold is much better. They expect a similar kind of response, and doctors don't take enough trouble to explain that no matter what class of antidepressant, it's going to be a while. The other thing which is less common is not explaining the possible side effects and not to be deterred by the occurrence of minor side effects. Major ones, of course, need immediate attention, like hypertension, but a little bit of drowsiness, a little bit of dryness of the mouth should not cause patients to veer away from taking the right medication, because we choose our antidepressants very carefully, but these two things, the latency of action and side effects, many doctors fail to explain to their patients. Some very avoidable sins.
Can we conceptualize depression?
Is there
through
anything
top-down
called
approach?
as acute depression and chronic depression?
Yeah, depression usually, like I said, most of the times unipolar depression would last somewhere around 9 months to 1 year. If it is persisting for a longer period, around 2 years or more, we call it chronic depression. There could be many reasons why if it persists for a longer period. So that needs specific evaluation. So the reason why it is persisting. Yes, we do see some patients.
Is it necessary for us to treat for acute depression cases, sir, or we can counsel them?
Yeah, so like I said, if it is a clinical depression, that will require some form of treatment. That can involve different form of psychotherapy, what people call as counseling, but there is a difference between both. So we're using specific approaches that way. You can also use medications depending on the severity and the other manifestations. Like I said, if someone is suicidal, there will be urgency to treat. So possibly we'll think about ECT or medications that way. But if it is a little milder form of depression and there are specific psychosocial issues or certain form of cognitive errors or certain things that you are identifying, interpersonal problems, which we will specifically deal with using certain form of psychotherapy. So, or it can be a combination of both. Sometimes we do both. Okay. So, so acute forms of depression basically mean if it is a syndromal depression, it is going to persist for a longer period. So there is no reason why it should not be treated, because it will cause a lot of let's say distress to the patient. If it is a subsyndromal condition, it will resolve. Let's say, like I said, no, if it is not persisting for more than 2 weeks, possibly it is not a clinical depression. We need not treat those patients.
Okay, thank you, sir.
I think Dr. Sameer's slides about how the various symptoms, the first slide about distress going on to severe sadness, normal sadness, that's very important. So if you just lost a dear one, it's very normal that you would be grieving and you will have sadness. You've had a heavy loss in your business you've had a major fight within the family. All these are known stressors that can bring about depression. They can, so the next slide, no, the latest slide, he showed you a whole lot of symptoms. You must meet the criteria of those symptoms. Just one symptom of sadness is not enough to diagnose depression. He clearly showed us in the cognitive realm, in the vegetative, neurovegetative realm, there have to be symptoms before we say that this is a case of depression. So look at that slide, that's very important. Look at the list of symptoms in there, and at least one from each category. I'm not sure that I agree with the DSM and ICD and their number is required. If you have one in every one of those realms, think of it as depression.
Oh, thank you.
Those slides were very, very useful, and I wish they could be circulated among IMA.
They will be streamed on our platform, sir. All this, the whole program will be streamed on the platform.
That slide is very important, as is the previous one, distinguishing between normal sadness and how to not mistake it for depression.
Oh.
Sir, what's the top-down approach where thoughts play the dominant role in depression?
Actually, I would say it is bidirectional. So it is very difficult to say. We will have different, you can argue for both, which is more important, thought or emotion. Both have role, and possibly in different persons, it will be slightly different. So you can say, you can think that way. And each of thoughts can affect emotion, emotions can affect thoughts. So you can take it that
Dr.
way.
Kumar, can we see you? You seem to be very interested. So pleased that you've generated so much discussion. Can we see you? Dr. Kumar? I'm sorry, I didn't mean to shut you up. In fact, I was very fascinated, very happy that you were one person taking so much interest. Dr. Harisha, shall we wind up now?
Yes, sir. We'll do that, sir. Kindly conclude the session, sir.
Right. Thanks, Harisha. I must congratulate Dr. Samir on bringing very real-life situations that we would encounter sometimes in the emergency room, sometimes in the referral, real-life stories of people who have different facets of depression. I just wish that he was working towards an interactive program where he asked questions. I was itching to give answers, but as chair, I thought I'd refrain from doing that. I wish people had been responsive to his interactive stimuli. Thank you, Samir, for a wide variety of cases, which I believe are culled from your own experience. And we do see that. In younger people, 2 cases he had, both reacting in an extreme fashion to a breakup in their romantic lives. To me, that emphasizes the values of younger people and how they forget there is anything beyond romance in life once they get attached to a potential partner. And I think we need to spend our time in educating younger people not to give up on account of what will eventually seem cost their lives, both males and females, in their youth because of these seemingly shallow values. We have no right to judge them and say that they have no values at all, but seemingly it is shallow at that time. And other hedonistic concerns, pleasure, pleasure, pleasure all the time. If I'm deprived of my pleasure, I cannot survive, is quite a common forerunner of suicide, especially among young people. We have great concern for the rising suicide rates among young people everywhere in the world, not the least in our own country. And I think we should spend more time with youth who have symptoms of depression, especially when they voice suicidal ideas. I would like to thank Dr. Sanjana, Dr. Harisha, and the IMA KSB for giving me an opportunity to listen to Dr. Samir Praharaj on this very important topic. As I've already said, but I'll say it again, Dr. Samir brought home real-life situations to us took us through the biology of depression, took us to the treatment of depression. If I must find fault, it's that psychotherapy is usually glossed over, but that's not his fault. It's a fault of an entire generation of mental health professionals. There are skills in psychotherapy. I wonder if you all can have another session where we address those issues also. Thank you very much for giving me the opportunity to chair this session, and over to the organizers.
Thank you, sir. Now it is a time to render vote of thanks. I thank our beloved President, Dr. Lakul sir, for being with us and who gave a opening remarks. Thank you very much. I also thank our Honorary State Secretary, Dr. Karunakar sir. I thank our Chairman of Academic Subcommittee, Dr. Sanjana Patel, Madam. And now it is my privilege to thank our beloved senior psychiatrist, Dr. Ajit Bide sir, who was the president of Indian Psychiatry National Headquarters, and who is kind enough to come over here for IMA KSB platform and enlighten our IMA members as well as the many postgraduates from Psychiatry Department. I thank you very much, sir, for this kind gesture. Thank you. I also thank Dr. Samir sir, who is the head of the department of from the Department of Psychiatry, KMC Manipal, who enlightened us about the pathophysiology of depression and using certain cases. And I thank you very much, sir, for coming to this platform and enlighten us. Thank you very much. I also thank many of the head of the department from different medical colleges, from Department of Psychiatry. I could recognize Dr. Shubrata, Dr. Poonam, Dr. Supriya Hegde, and many more who come to our webinar, and thank you, each one of you. I also thank our postgraduate who are with us for this particular discussion. I thank our digital manager, Mr. John, also. I thank one and all. Good night.
Good night and greetings on Republic Day tomorrow. Let us be
Thank you,
more
sir.
committed
Thank you.
Indians.
Thank you.
Thank you. Thank you.